Hello, everybody. It's a brave new world. This is my first webinar, so I'm going to try to make it look good and answer a lot of the questions that I get on a daily basis with my patients. So, and the format today will be I'm going to give you a brief presentation, probably about 10 minutes, and then you'll be able to type in some questions at the end. And I'll just run through the questions and answer them, and let's hope it goes well. Also, this will be available on our website. There are several videos and presentations available on our website during this down period. I personally made about 4 or 5 videos which are on various topics. That's the wave of the future, and I think they would be helpful to people who have a lot of questions. So the subject on the table today is bunions. What are my options? So the point I like to make with a lot of patients is everything's quite individualized, and not all bunions are the same. People think they have bunions, they don't have bunions. People think they have a big bunion, they don't have a big bunion. What a bunion is if you see my pointer over here, it's a bump on the inside of your foot, and it's caused by this bone called the first metatarsal drifting out of position a little bit, and that's mainly on a genetic basis. And I think any surgeon who deals with a lot of these has to decide, well, first of all, you have to decide, help the patient decide, is it worth it to do something or not? Is it necessary to do something or not? And then if you're going to do something surgical, what are the operative approaches? So the first thing I want to show you is someone says they have a bunion. My friend has a bunion. My foot's just like someone I know. They're not all the same. So this is a relatively moderate bunion, and you can see this angle between these two bones. This one you can see is a little bit worse. There's a little bit bigger angulation. The toes heading off to the right a little bit more, and the bump's a little bigger. The angle between these two bones is bigger. This one is really even worse. So you can see that, again, the angulation is bad. The toe is going over quite a bit. It's bilateral, meaning both sides. And on a technical basis, there's some issues down at the base of this joint here. And I'll get back to that in a moment. Yeah, someone who really waited, and you can see what we see here is that this angulation is very bad. Often people, by the way, ask me what this bone is that I'm circling here. That's called a little sesamoid. They're always underneath the big toe. And when you see them, it's because actually the first metatarsal, which is this bone, has moved out of the way. In addition, what's interesting here is that her toe is totally twisted 90 degrees. So logic tells you you cannot treat this bunion the same as this bunion, the same as this bunion, or the same as this bunion. So how do I think about it? One last thing. This patient has a different kind of bunion which is the bump on the inside, and then the joint is pretty arthritic over here. Look at the nice space on this individual's left side, and you look at the absence of space on the right side. So this type of patient comes in and says, I have a bunion, it hurts. Well, yeah, you have a bunion, but it's really arthritic. And this is a side view of exactly the same patient. And you can see this individual has an enormous spur on the top of the big toe, and the joint is arthritic. So there are about 5 different examples of, quote, bunions, and they should all be approached really in a different fashion. When I meet a patient, I think the approach really needs to be individualized. I have to understand what the patient's expectations are, what kind of shoe wear they want to wear, how much downtime they really want to put into all of it, what their age is. All of these factor in. There's no specific one point that is determinative, but I like to hear about all of these things and talk to patients and understand what their needs are. Our goals really are pretty simple. What I want to do is create a number one pain-free foot. I and most orthopedic foot and ankle surgeons really do not want to do a purely cosmetic foot. I think it should look good when we're done, but to do it for purely cosmetic reasons is probably not the primary goal. Most patients who have their bunions corrected, it's because they want a pain-free foot or a close to pain-free foot. Fitting into shoes comfortably is very important for patients. You can imagine some of those x-rays I showed you before would be a tremendous challenge to fit into shoes. Lots of people want to exercise. A good-looking foot is usually a good functional foot. So if the foot looks good when I'm done, it's almost always a great result for the patient because form follows function. Function follows form, they both do. So these are the goals, and we want to think it through for each individual patient. So I do maybe 5 or 6 operations for bunions on a regular routine, and I think most surgeons who handle this kind of problem should have a good degree of comfort with several different approaches. The decision to proceed, as I said, is made in collaboration with the patients. And I've had many patients over the years. I might see them and then they decide, oh, the recovery is maybe not be worth it to me, or I can't take the downtime, or I need to be traveling too soon. And we put it off. And then I see them a year or two later, or 3 or 4 years later, and then we can approach it. I always tell people, don't worry about it. We can always fix it. There's never a foot that you can't fix. What we may do may change as the foot gets worse, because it tends to get worse over time, but it's not going to be beyond repair. So if we look at this patient, on your left is, oh, let me go back, sorry. On your left is the before, and this is the after. And this patient has an angulation between these bones that isn't too bad. Got a bump over here, and the toe's going that way. The left foot is milder, but this is someone who I've gone through everything, and the foot is really bothering her. So what I do in this kind of case is I shave off the edge over here surgically, cut the bone, and use a little dissolvable pin. That's why you don't see any metal on this x-ray, and make another little cut there called an Aiken osteotomy. The beauty of the surgery is that we do it on what's called popliteal block, which means you come in an hour before, anesthesia gives you a little sedation, they numb you up behind your knee, and then you're numb actually for about 20 or 30 hours, but you're only there for 3 or 4 hours. So it's an hour before, takes an hour plus minus, then you get something to eat and drink, and then you head home. When you get home, you won't have any pain at all, but when the block wears off, you may have some pain. That would be about 20 to 30 hours after the block was given. I'd say about half my patients, believe it or not, get away without anything more than Tylenol or Advil, and the other half require a narcotic for a day or two. But it's the popliteal blocks, I believe, have revolutionized our care in the sense that patients have much, much less pain than they did before our anesthesia colleagues perfected that. So that's version 1. I call that a chevron Aiken, and it's a good go-to operation. I just did one today. This would be a common procedure. I call it a proximal bunionectomy with Aiken. I do actually what's called a proximal chevron bunionectomy, and there are videos on this that I've done. And this would be for a moderate to severe bunion. Again, if you look at this individual, the angle between the 2 bones is a little bigger than the last one. These 2 little kneecap sesamoids are a little more out of place than I would like. So I don't think I can get adequate correction through the end of the bone over here. And therefore I want to go a little bit lower. It's just geometry. So I cut the bone at the base, swing it over. See how nice and parallel this bone and this bone are? And then I have to, in this case, hold it with a metal plate that's specially designed for this area, which corrects what we call the intermetatarsal angle, makes these 2 bones parallel. and then correct all of this soft tissue here with a little Aiken cut here. And you can see what a nice result she has before and after. That's a good workhorse procedure, and I do many of those. I did one yesterday. I've got several, usually several every week. Now, this individual I showed you earlier has a very big angle between these bones. Also, there's some indication that there's too much looseness at the base of this bone over here. So instead of cutting the bone, and this is a severe one, it's a male, and men tend to wait a little bit longer than women because they can wear more accommodative shoes for longer. And he was fairly stiff through this joint. So I elected to do what's called a lapidus fusion. So this would be for a more severe bunion. And instead of breaking the bone at the base over here, I fuse or weld these two bones together. And this is especially designed, a metal plate and screw that helps me hold the bones together until the bones have healed. You can see how nice and parallel he is before, after, a little Aiken cut. That's a good correction. I did the same on the other side at a later date. Just as a matter of interest, the metal tends to not bother patients. I would say 1 in 10 have it out. It's dramatic on x-ray, doesn't set off airport alarms. 1 in 10 I have to take out. To take it out is not a big deal, but the beauty is it lets me allow you to put weight on it pretty quickly. And this is another patient that you saw a little bit earlier with a very, very severe angle over here. And instead of doing 1, 2, 3, 1 wouldn't work, 2 might work, 3 might work. I did what my fourth operation, which was to fuse this joint or weld this joint together over here. And you can see this is actually the same patient before and after, and before and after. And I ended up doing the other side at a later date. I don't like to do both at the same time in most circumstances. And this is a very, very satisfactory way to correct an extremely severe bunion. Now, a patient like this would have a little limitation in heel heights, maybe up to 1.5 inches or so, but it's durable and will not recur. So that's a terrific salvage out of some difficult situations. This would be a tough foot to do under any circumstances. And then the last group that I wanted to talk about was a patient who's not only got a bunion, but if you look carefully at this joint, you can see that there's not a lot of space in the joint, not a lot of space, as say compared to these joints are beautiful. And so this is an arthritic bunion. And if you try to do any of the first 3 operations, they're going to fail. You'll get a straight foot, but you may have an unhappy patient because that patient would have pain from the joint. So you're best off, again, fusing or welding the 2 joints together, corrects the alignment beautifully, and that is durable. You can run, you can play tennis, you can play squash, whatever you want to do. It's a good durable operation, but it does limit the heel heights a little bit. So just to summarize, and then we'll go to some questions. There's a complexity to all this, and I'd be cautious of people who oversimplify the situation. Each patient has a specific need and goal, which may differ from patient to patient. So you could have the exact same x-ray on one patient as on another patient. We might take a slightly different approach. It's very important that the patient and I understand what the goals are, what we're trying to do. And I think that allows us to achieve the expectations that patients have. It's also very important that patients have a clear understanding of what the recovery will be. I often tell people recovering from bunion surgery is like going from New York to California. I'd love to get you there in 2 hours, but it's going to take you 6. So bunion surgery just takes a little bit of time, and you got to be patient. And I usually put together a timeline for each patient and print it up and say, look, this is what's going to happen at 2 days, 10 days, 4 weeks, 6 weeks, and so forth. I do think whoever does the surgery should be adept at multiple procedures because you just cannot correct everything one way. Patient selection and careful preoperative planning and teaching is critical, and that's a little redundant there. And I think that results are predictable. They're very good. If the patient is well informed about what they're going to go through and how long it's going to take, and the surgeon adheres to fundamental principles and doesn't get too far off the line in terms of what the right way to address a specific problem is. I've been doing this a long time now, and every year or two there's some newfangled idea that comes out that's supposed to be the easy route. And I would caution you about that, because if it was so easy, everybody would jump on that bandwagon. And as a last factor, a last comment, your first shot's your best shot. So I didn't show you any revision procedures or anything of that nature. It's always a little tougher when you got to go back in and revise something. So your first shot's your best shot. You certainly can fix a bad result, but be careful about the decisions that you make, and try to go through the sort of checklist of, okay, what am I expecting, and is it a reasonable expectation? Thank you for joining us today. And what I'm going to do is switch off this PowerPoint in front of us and see if anybody has any questions. So I think those of you who are technically adept, there's a way to put in some questions. And I don't see anything up there right now. Our moderator is Cindy, and I'm going to see if she has anything to say to me. Well, I don't see anything coming up, so I'm sure everybody's got a lot better things to do than watch a webinar on bunions. I'm happy to talk to any of you in person. You can look through some of the presentations we have on our website. This webinar will be posted online. Hopefully we did a reasonably good job, and we'll see you next time. Thank you.